In this video, we'll discuss about the Alzheimer's disease. It is a progressive neurodegenerative disorder and the most common cause of dementia in older adults. It causes a slow decline in memory, orientation, language, and behavior, and the pathology begins years before symptoms appear. What actually happens? The exact trigger is unknown, but Alzheimer's develops from genetic risk, abnormal protein processing, and synaptic failure. The earliest damage happens in the hippocampus, the brain's memory center. As the disease spreads through the cortex, more functions collapse. We know that the temporal lobe involvement causes language problems, parietal lobe causes spatial disorientation, frontal lobe for judgment and planning. Later motor dysfunction, swallowing issues. The disease starts with amyloid beta accumulation. Abnormal cleavage of amyloid precursor protein produces a beta-42, a sticky, toxic peptide. These fragments accumulate outside neurons as amyloid plaques, triggering inflammation and early synaptic dysfunction long before neurons die. Inside neurons, tau, normally responsible for stabilizing microtubules, becomes hyperphosphorylated. It collapses into tangled filaments known as neurofibrillary tangles. The spread of tau pathology correlates most strongly with the severity of cognitive decline. Neurodegeneration begins in the hippocampus, leading to early memory issues, then spreads to the temporal and parietal lobes, affecting language, visuospatial skills, and executive function. There is also loss of cholinergic neurons in the nucleus basalis of Meynert. Genetics play a major role. APOE-epsilon 4 significantly increases the risk of late-onset disease, while mutations in amyloid protein precursor, presenilin 1 and presenilin 2, cause early-onset familial Alzheimer's by increasing a beta production. Trisomy 21 also confers early risk because the APP gene is on chromosome 21. Clinically, we can divide it into different stages. Early stage includes difficulty forming new memories, repeating questions, misplacing items, mild word-finding problems. Middle stage involves language impairment, disorientation, behavioral changes, irritability, apathy, social withdrawal, difficulty with daily tasks. In late stages, global cognitive failure, loss of speech, incontinence, immobility, full dependence for care. This disease is progressive and irreversible. Alzheimer's is a clinical diagnosis supported by cognitive testing such as the Montreal Cognitive Assessment or Mini Mental State Examination, which typically show impaired episodic memory and deficits in visuospatial and executive domains. MRI often demonstrates hippocampal and medial temporal lobe atrophy. PET imaging reveals temporoparietal hypometabolism. CSF biomarkers showing low AB and high tau proteins support the diagnosis. Laboratory tests are essential to exclude reversible causes such as vitamin B12 deficiency and hypothyroidism. Treatment remains symptomatic. Cholinesterase inhibitors such as donepezil, rivastigmine, and galantamine enhance cortical cholinergic activity and are useful in mild to moderate disease. Memantine, an NMDA receptor antagonist, is used in moderate to severe stages to reduce excitotoxicity. Anti-amyloid monoclonal antibodies such as lecanemab have shown modest benefit in early disease. Supportive care like optimizing the environment, managing behaviors, supporting caregivers, and addressing nutrition, infection risk, and safety forms the backbone of long-term management. Alzheimer's results from amyloid plaque formation, tau tangle accumulation, and progressive cholinergic and cortical neuron loss, beginning in memory circuits and spreading outward. Early recognition and structured support greatly improve quality of life. Even though the disease remains progressive, this is the Why Medic. Simplifying neurology, subscribe for more high-yield topics.